The next talk is another rapid-fire talk. Rectus sheath block improves patient recovery following open aortic surgery, presented by Dr. Cleary, with senior author Dr. Gifford from UConn, Hartford, and the anesthesia group at Hartford.
Hello, my name is Colin Cleary. I'm currently a second-year medical student at UConn, and today I'll be presenting our work on rectus sheath blocks and how they improve patient recovery following open aortic surgery. How do I? Oh, perfect. Here are our disclosures. Postoperative pain management after open abdominal aortic surgery remains a significant barrier for hospital discharge and patient recovery. There have been several studies that have suggested that adjunctive analgesic therapies like epidurals have helped in controlling patients' subjective pain scores and outcome measures like length of stay. However, there's an overall paucity of data supporting the utilization of rectus sheath block for postoperative pain management in this patient population. As such, we were interested in assessing the efficacy of adjunctive rectus sheath block for postoperative analgesia and recovering following open aortic surgery at our institution. In order to assess this, we first identified patients that received elective or semi-elective open aortic surgeries at Hartford Hospital from 2017 to 2022. We excluded patients who received emergent surgeries as well as patients on chronic preoperative opioid medication as defined by current daily prescribed opioid use in an outpatient setting. With the remaining patients who did qualify, a retrospective review using the VQI data extraction as well as our own internal EPIC data extraction was conducted and collecting intra and postoperative opioid utilization, ketamine usage, type of rectus block, including continuous versus single shot, and other postoperative outcomes like length of stay and pain scores. In total, 106 patients were captured, 12 of which had epidurals, which were excluded. 13 were non-elective, which were also excluded, which left us with 81 patients that fit our criteria. Of those, 44 of these patients had general anesthesia, while 37 had anesthesia with a rectus block. Of note, 27 of these 37 patients had a continuous infusion, while 10 had a single shot. And it's important to note that the demographics were similar with all of the 81 patients that we included in the subject or in the study, while the 94 patients had an increase in retroperitoneal exposure for general anesthesia, and there were also more elective procedures with the rectus block before we excluded the non-electives. So in terms of intraoperative pain management, patients who received general anesthesia with rectus block were found to have lower rates of procedure morphine milligram equivalents, or MME, and lower time to extubation compared to the general anesthesia group. In addition, patients who received a rectus block were also found to have higher utilization of ketamine intraoperatively, with no change in procedure time between groups, even including time for the rectus block by the anesthesia team. Looking postoperatively, patients who received general anesthesia with rectus block were found to have lower 0 to 24-hour postoperative MME, lower postoperative resting pain scores, lower utilization of PCA pumps, and lower discharge MME. They were similarly to our intraoperative findings. There were also higher postoperative ketamine usage with the rectus sheath blocks. And in summary, patients who received perioperative rectus sheath block were more likely to utilize fewer opioids during and immediately after the procedure, have a lower 24-hour subjective pain score, be not as reliant on PCA pumps, and be discharged with fewer opioid prescriptions. Having said that, some limitations of the study include potential confounders with additional adjunctive measures like the increased use of ketamine at the institution. Also, there are some differences when we stratify continuous versus single-shot rectus sheath block, namely discharge MME, but that was due suspectedly to decreased power of the group. And then some other postoperative improvements like length of stay may be confounded by a general push from the department to enhance recovery in these patients. Thank you, and I'll take any questions at this time.
Thanks very much. Is this something that your anesthesia group is doing commonly in general surgery patients? Because this is relatively new, and I've had the anesthesiologist come up to me lately and say, "Do you want a rectus block?" And I'm sure.
The anesthesia group is very willing to do rectus blocks. They do them in other surgery types. I'm not aware if they're doing them just pan for any general surgery procedure, but from the results of our study, we're definitely advocating for more use of rectus block for pain control.
Did the nidus for this come from the vascular group, the anesthesia group, or both? Who started the idea of doing this for this patient population?
I'm not aware of who initiated it, but I know there's a big push from the anesthesia group, and we've accepted the idea of doing rectus blocks based off of the anecdotal improvements in our patient recovery.
Hey, Nathan Lang from Pittsburgh. I really enjoyed your talk. I think there's a really big push overall towards adjuncts for pain control in open aortic surgery. For us specifically, we hate epidurals as well because they cause all sorts of problems, so we've moved to paravertebral blocks rather than rectus sheath blocks. But most of this, I think, really, we've been trying to wrap into this whole idea of an ERAS, enhanced recovery protocol, and that's been something that we've been really trying to push. You did mention it on your last slide, and that was going to be my major question. I guess, were you able to, first of all, wrap this into any kind of ERAS protocol in your day-to-day, and also are you able to track whether or not that has any effect on what you're doing here? That was a fantastic talk. Thank you.
Thank you. Yeah, that's a great question, and this is sort of the first step in doing that. We're going to go forward with a prospective to really stratify if this is truly an effect in a lot of different aortic surgeries and maybe some non-vascular procedures to initiate that protocol creation in our institution.
Great talk. This is Mimi Kwong from UC Davis. For your single shots, are you using a different analgesic than the continuous? Like, are you using a longer acting formulation? And then also, with the single shots, are you able to give those prior, or are these all done post-surgery?
That's a great question. Thank you.
Sure. I'll jump in for Colin, even though he's been doing a wonderful job of answering all these questions. So, we don't have access to liposomal bupivacaine at our institution. It's only being able to be used in a prospective clinical trial fashion. So our anesthesia group actually, as Colin alluded to, is very, very active in this, and our hope is to go forward prospectively and look at single-shot liposomal bupivacaine versus the continuous catheters. We really don't think that the single-shot short-acting bupivacaine has much of an effect. We do this at the end of the procedure, and our regional block team is very active. They stay late. They don't leave at like 3, so they'll be in the OR at 5 o'clock, scrubbed, ready to go as soon as we put the skin glue on the abdominal incision. And, I think paravertebral blocks are an excellent option, especially for retroperitoneal exposure. We tend to do predominantly transabdominal. So I think that answered most of those, but thank you very much.
Chuck Fox from Baltimore. That was very nicely presented. Good job. Congratulations on sort of pushing the envelope on helping our patients postoperatively. We have a big dialysis patient population in the D.C., Maryland metropolitan area, and I started doing laparoscopic peritoneal dialysis catheter placements. And when I would use some of these techniques guided by the laparoscope, I noticed that the patients could really get out of the PACU quicker and go home the same day. So I'm a big fan. And when we were doing rib fixation in the trauma center, the liposomal bupivacaine made a big difference, although it is expensive.
Yes, thank you for your comments.
Great job. Thank you.
Thank you.